Hey, we're going to roll right into session 3, our final speaker session before our panel session to wrap up the evening. And with this, keeping in mind that third pillar, solutions for challenges in rare disease care and support. So our final speaker session of the evening focuses on that care and support. Diagnosis and treatment are only part of the story, of course. It's a question of what happens beyond the medical care, the medical space, and during the journey that matters just as much. Acknowledging the multidimensional needs encompassing psychological, social, and home care needs. We'll hear about programs that support youth transitions, empower families, and close the gaps in our system. So to begin that, we dive into exploring the unique needs of patients with rare diseases as they transition from pediatric to adult care. No question, a challenge in the general population, let alone those with rare disease. We invite to the stage Dr. Michelle Batthish. She's a pediatric rheumatologist at McMaster Children's Hospital, an associate professor of pediatrics at McMaster University. She's also the physician lead of ambulatory care at McMaster Children's Hospital and vice president of pediatrics at the Ontario Rheumatology Association. Her clinical and research interests are in healthcare transition in patients with chronic rheumatic disease and quality improvement in pediatric rheumatology. Dr. Batthish.
Thank you for that introduction, and thank you for inviting me today and allowing me to share some unique challenges that patients with rare diseases face as they transition from pediatric to adult care. But let's step back and just talk about transition to adulthood in general. So transitioning to adulthood is inevitable. We've all done it. Presumably, we've all become adults. But it is a very challenging period, as you can imagine, if you think back to your own adolescence as you became a young adult. It is challenging for youth. This period shapes the pathways of youth to health and quality of life across the entire life course. And we know that there are societal expectations of us at this time. We have to take responsibility for oneself. We need to become more independent in our decision-making, and we have to learn to be self-sufficient. So let's layer now the fact that some youth have chronic health conditions, and that period now becomes even more challenging. We now add this aspect of healthcare transitioning. So these children now have ongoing medical visits with different and changing healthcare providers. They also need to learn to adhere to their medications or other therapies on their own. And of course, there's concerns around risk-taking behaviors and how that may affect their underlying condition or treatments. Beyond healthcare, these children or youth are transitioning to post-secondary education and employment, and there are additional barriers in access to appropriate supports, services, and accommodations. So what about those with rare diseases? Unfortunately, there are large gaps in our understanding of the unique needs and challenges faced by adolescents and young adults with rare diseases. These patients often have specialized multidisciplinary care, and often there are lack of adult care providers who have specific knowledge of their rare conditions. And so often there's no one to transition to. And of course, we have to realize that some of these patients may not live independently. And so now we have to add in the fact that caregivers also have to learn to transition from the pediatric system to an adult system. So let's just go over some definitions. So what is transition? So it is not just a simple administrative transfer of care. It is the purposeful planned movement of adolescents and young adults with chronic physical or medical conditions from a child-centered to an adult-oriented healthcare system. So why does this matter? Well, fortunately, pediatric patients with rare diseases become adults with rare diseases. So we're very fortunate for that. But we need to appreciate that the adolescent brain is under construction. I am living through this now with my own adolescent child, and every day is a surprise. There are biological, psychological, social changes that are occurring during this time, and we need to take that into account because the pediatric healthcare system is very different than the adult one. So the Canadian Pediatric Society acknowledges this and have put out a key position statement highlighting some of the key elements of transition planning. And they highlight 5 elements that we should consider. The first is that it needs to be patient individualized, and we have to be flexible based on the developmental need of that patient. That we need to work towards acquisition of self-management skills so that these children know more about their medical condition. Shared decision-making is key. Prior to transition, many of these decisions are made between the healthcare providers and the caregivers, and that needs to shift towards the youth making some of these decisions on their own. Of course, communication between pediatric and adult healthcare providers is essential, and we need to start early. We can't just bring this on a family at their 18th birthday to say, you now must go to an adult provider. You have to start as early as possible. So what do we do at McMaster? In my pediatric rheumatology clinic, we're fortunate to have a multidisciplinary and collaborative approach to transition. We have a pediatric nurse involved, and in addition to the pediatric rheumatologist, an adult rheumatologist joins us monthly in our clinics, along with our physiotherapist and a child life specialist. We see patients as young as 14 with chronic rheumatic illness, and these patients are seen routinely in our clinic up until their 18th birthday. And during these assessments, in addition to dealing with the medical issues between both the pediatric and adult rheumatologist, these patients are assessed for transition readiness by our allied healthcare team. And so what we use is a questionnaire called the Transition Q, and this is housed on a free app called the My Transition app, which was developed at McMaster. The Transition Q is a 14-item validated questionnaire that asks patients what seem like simple questions, but go and become more complex. So one of the questions may be, I can ask the doctor or nurse questions on my own. And that could lead to question 14, which is, I am responsible for my own prescriptions. And so at every time they come to our clinic, they answer these questions, and then they meet with our child life specialist and try to reach different goals. So moving from answering never to sometimes to always to all these questions. And what we found in our patients who have either JIA, which is juvenile arthritis, or childhood onset lupus, is of course readiness increases with age. So no surprise, as children mature, they become more ready. But what was more interesting is that there was significant variability in readiness scores among children or youth within the same age. And so someone who may be 17 may not be as ready as someone who is 15. So this highlights the need to have an individualized approach to transition. Well, what about the parents? We know, and I hear it all the time, stepping back for parents is hard, and preparation has really been focused on youth with very few resources available to parents. And if we remember those with patients with rare diseases, their parents and caregivers may continue to be involved in their care beyond 18. And we know that parents struggle with this change in role and identity. This is a quote from one of the parents who I spoke to, who says that with all my resources and preparation for transition, I felt like my son fell from the cliff when he entered adulthood. It is a scary place to be for someone with complex needs. With that in mind, our team co-produced, along with some parents and patient partners, a transition toolkit. And in this toolkit, we have a parent guide. In that guide, it highlights some basic roles that parents can have during the transition process and highlights some key differences between adult and pediatric care. Alongside this guide, there is a transition roadmap that is given to the youth that highlights some key elements and tasks that they should learn throughout the transition process. And with the implementation of this toolkit, we were able to show an increased readiness to transition as measured with the transition Q. Fortunately, we have now successfully translated this document in 6 different languages, which will soon be available. And you can scan the QR code, and that will take you to our university site that has the link to these guides. And I should highlight that these are not disease specific. This one says rheumatology, but in our newest edition, it is generic in the sense that it can be used for any chronic illness. So just to finish off about some future directions with our transition research. We are just wrapping up a pilot randomized controlled trial on a virtual transition coach intervention. So patients who are either approaching transition or who have already transitioned to adult care get to meet virtually one-on-one with a transition coach. So this is an allied health provider who meets with the youth in between their medical appointments. And during these sessions, they get to talk about all the non-medical aspects of transition so that they are better prepared for the visit with their healthcare team. We're also developing and soon we'll be validating a parent transition readiness tool so that we can measure readiness on the parent or caregiver side. We can't ignore the fact that mental health is a key element in all of this. We know that there is increasing mental health conditions in youth with chronic illness and in those with rare diseases. And we need to continue to monitor through regular screening for mental health conditions in our patients. And finally, I wanted to highlight my involvement with Rare Kids Can as the subplatform lead for transition to adult care. And our work has just been is beginning. So we are firstly looking at the unique needs during transition to adult care for those with for those with rare diseases by doing an in-depth dive into the literature of what is already known so we can identify some areas for improvement. We will then look at exploring the barriers and facilitators to participating not only in clinical trials, but in transitioning in those patients with rare diseases. Ultimately, our research and advocacy work will empower youth with rare diseases throughout this process. So I'd like to end just with some acknowledgements with the team of both pediatric and adult providers, but of course our patient and parent partners who have really helped guide this work. And I'm open for questions. Thank you.
Question from the floor.
I have a question about mobile application, which is free. Is it for all rare disease could be used, or it has specific question related to autoimmune disease?
No, so it is not specific to any condition. Anyone can use it.
What else? Oh, yeah. I don't see any questions online.
Yeah. So thank you, Dr. Batthish. Can you say something? How do you support the platform and questions and all of this? I think one of the things all of us have challenges with is sustainability of these kinds of tools. How do you manage that in your center?
I think the first step is with research and by showing good evidence for its effectiveness. With that, then you can advocate at the hospital level to hire the right people and provide the resources needed. One thing I did not show is at least within the rheumatology community, we developed also a paper position statement on the importance of transition because we appreciate the lack of resources on the adult side. That's the key. We are fortunate in pediatrics to have social workers or physiotherapists in our clinic. The adult providers don't. And so ongoing advocacy is essential to ensure that the right resources are available.
Dr. Batthish, thank you.
Thank you.
So as we turn the corner to the second set of speakers in our final speaking session, we want to look at community engagement and the research taking place in that aspect and what is the PACER program. I want to bring to the stage Dr. Deborah Marshall, who's a professor in health economics, value and impact in community health sciences at the University of Calgary. She's also the scientific director for research and partnership evaluation and impact at Alberta Children's Hospital Research Institute, and One Child, Every Child, Value Impact and Knowledge Mobilization Co-Facilitator. She leads the health economics, socioeconomic benefits, patient preferences, and patient engagements activities for several national and international research programs in precision health and patient-oriented research. She is joined by Jessica Head, a mother of three, a rare disease advocate, and current trainee in the Patient and Community Engagement Research, the PACER program at the University of Calgary. Her journey into research and advocacy began with her daughter Ava's diagnosis with Kabuki syndrome, a rare genetic disorder that reshaped her understanding of healthcare, community, and the transformative power of lived experience. With a professional background as a chef and holistic nutritionist, Jess brings a unique perspective to patient-oriented research. And in addition to her work with PACER, Jess recently joined Rare Kids Can as a parent partner. Welcome to the stage.
Yeah, that's great. Thank you. We did not stage that, but it worked out perfectly. Thank you. So welcome. What a perfect setup. I'm so appreciative for all of you for being here at 8 o'clock at night after a long day's work and still hanging in there. But I'm really excited to spend a few minutes, and I'll try to be really brief and happy to chat. I'm always happy to chat lots after or whatever suits. But what I'm going to do, I had to move it, is really talking a little bit about engaging patients. And the bottom line is you don't get anything out of this evening, which I know you have, is we need to do this together as a community. And that's really the message, if nothing else comes out of my presentation. But what I want to do is share my journey really as a researcher in discovering and working with patients. And this started a while ago in my research journey when I was at community health sciences rounds, and a senior colleague of mine was presenting, and I said, gee, I really think I need to understand more about this. And she goes, yes, dear, you need to do community engagement stuff. And I said, oh, okay. And we actually got a grant together, and we got a grant on community engagement, and we started what has now become PACER. And we started in osteoarthritis, a chronic disease. And she was an expert, Nancy Marlette is her name, in participatory action research and citizen science. And she's completely changed the way I do my research and things. I change things. So I thank you, Nancy. So let me tell you a little bit about this. I can't see. Okay, I'm seeing. Okay, that one's up now. The whole point of PACER is that it's about being part of the team. And before we even knew how it was going to evolve, how it was going to evolve, rather, we said we're going to build new roles for patients and relationships in doing our health research. And I won't go through all of this. There's some references that I guess for us were baseline seminal references, which, believe it or not, were 10 years ago. And I know lots of you do community engagement. To my knowledge, I think PACER is still the only program in the world that actually is a certificate from the university. It's a certified program in the graduate, in community education. I'll tell you about that in a minute. But what it is a fundamental cultural change, actually. We work together as a team. This was set up as what we call the twin innovation with the Alberta Health Services Strategic Clinical Networks. And we did this all together with our patient partners. And this is how it works. It's not for the faint of heart, and it is not the solution. Jessica is chuckling over here. She's still standing, but I know she's working very hard. But it is on one end of the spectrum about how the extent to which we actually can potentially enable and partner with some members of our community. And so this is a 3-part program. There's 3 courses. It's 160 hours of in-class training. Okay, that's actually more qualitative research training that most of our graduate students get, actually. Just saying. And in addition to that, they do a project. They have to conceive it. It goes through ethics and it's reviewed by UC, regular ethics. They don't get special treatment. And that's hard. And then they actually execute the research themselves and write it up in a report. And some go on to do publications, et cetera. So these are the learning outcomes. I won't go through all of them, but they learn theory. Where does qualitative research come from? How do you approach it? What are the methods? Doing interviews, doing focus groups. And they learn how to define a research question and execute a project. So just to give you a few examples, we've done this a lot in our IMAGINE, which is our inflammatory bowel disease microbiome strategy for patient-oriented research, SPORE program, which is a CIHR program. These are just 2 of them, okay? We did 2 cohorts a few years ago, one which called themselves the Mob. We did not give them that name. The other called them We've Got Guts, and here they are, working together. We only had this in person at that time. And then I just want to highlight, and it works perfectly with Dr. Battish's presentation. I did not plan that. Was we had the first youth cohort ever, which was our childhood arthritis, JIA, and they studied transitions from childhood to adulthood, and they did this kind of work, and they went on to publish it. They are the authors on this. Yes, we help, we work with them, etc. But this is a scientific publication that they produced. And trust me, these people are not to be held back. One has founded a charitable organization called Take a Pain Check. She does podcasts every week or every day or something. I don't know how she does it. She's boundless energy. She's part of our childhood arthritis You Can Do program. She works with Dr. Batthish. Like these people are just unbelievable in terms of the kinds of things they've done to mobilize the community, engage in research, be partners on our research grants, and really change how we do things. So that just leads up to our background in the rare disease side. I didn't want to talk about our whole research program, but we have been working in the rare disease space through Care for Rare. You've seen that before. We have the childhood arthritis, which is a rare disease in its subforms. We've created PAVE, which is a European program that's looking at transitions and supporting how do we bring in this broad view of rare disease and create platforms. Some of you in this room are on RADAR, thank you, which is looking at how do we code rare diseases. And we have a rare disease patient cohort. Sorry, I didn't put them in the right order. So we have started and launched in 2025 a rare disease cohort. This is with parents with children with rare diseases. Many of you in this room are parents with rare disease children. And on the left, you can see the 6 names of our members of that cohort, and several of them are here today. And this is my segue to introduce Jessica Head, who is one of those who is in the midst of this program. She's done course 1. They're defining their program. And I'm just so incredibly proud. And I'll go back to the first speaker, Ashley, who said, we can do this. You know, we are the experts. People with the disease and their parents, in the case of children, really know a lot about their disease, and we have so much to learn from them. And that's how I think we can really move things forward. So thank you. And thank you, of course, to all our sponsors, supporters, funders in our programs. And over to you, Jessica. Please welcome.
Thank you.
I can share.
I better lift this up a little bit more. Good evening, everyone. My name is Jessica. For those of you who I have not met yet, I'm truly honored to be here today alongside Dr. Deborah Marshall to share how the PACER program has impacted my life. See a familiar face over there. You can see up on the screen, I have a few photos. The one to the left is my daughter, Ava. We spent 67 days in the NICU. So bittersweet, of course. I was so excited to meet my beautiful daughter that I've waited years to meet. But it was a very, very dark time for me. We live just outside of Calgary in Crossfield. We're not from here, no family around, limited support. And it's hard to really go to friends that don't quite understand what you're going through when it's such a dark time. So I felt powerless and voiceless. I'll never forget the first time the nurses asked me to participate in rounds. I was so nervous, I thought I might pass out. So to be here in this room with all of you is very special. As a mother of 3, my journey into the world of rare disease began with Ava. We were searching for answers to her complex medical challenges, answers that eventually led to a diagnosis of Kabuki syndrome. As most of you know, it's a rare genetic syndrome, a rare genetic disorder. That chapter changed everything for our family and set me on a path I could have never imagined. My background is in culinary arts and holistic nutrition, a field I was deeply passionate about. But stepping into the world of rare disease was something entirely different. I suddenly found myself navigating a complex medical system that felt very overwhelming and very unfamiliar. I was completely out of my comfort zone, but I had no choice. I had to learn. I had to start asking questions. That journey led me to the Family Engagement and Research course, and some of my lovely teachers are over there. Thank you, which was a turning point for me. Gaining knowledge felt empowering. It was like slowly reclaiming a sense of control over our chaotic, unpredictable life. Then I heard about PACER, and I knew instantly that's what I needed to do next. So I took the leap. I closed my personal chef business, enrolled in the program, and I haven't looked back. Well, it's probably a lie. Someday. It's intense. I'm not going to lie. The PACER program has been truly transformative. It's not just a course. It is literally a community that uplifts, empowers, and recognizes the value of lived experience. It's helped me find my voice in research. I've gained tools, confidence, and a deeper understanding of how to contribute in ways that reflect the realities that families like mine face every single day. Since starting PACER, doors have opened that I never thought possible, from engaging in meaningful research projects to joining Rare Kids Can as a parent partner. I'm growing as an advocate, a collaborator, and at the ripe old age of 43, a lifelong learner. When I complete this program, my hope is to focus my energy on building community within the rare disease world. I see so many families struggling, not knowing where to turn for support, guidance, or even just someone that understands. I'm not an academic. I'm not going to cure any diseases. But if I can help in my own way by sharing our story, our journey, our struggles, and support even one other family, that's where I want to make a difference. To be honest, I still have moments, like right now, when I don't feel like I belong in these rooms. But what PACER has taught me is this: lived experience is expertise. It is essential to building healthcare systems that are truly patient and family-centered. Ava is the reason I'm here, and she is the reason I keep going. She's so cute, and she's just so sweet, and she is the most determined little girl. Thank you to the PACER community and to all of you, and to Svenja for asking me to participate, for believing in the power of lived experience and helping parents like me turn pain into purpose.
if I may, Jessica, at the ripe age of 43 and a lifelong learner and someone who feels like I don't belong in this room, and also now knowing the other side of that, that every researcher and physician and community partner in this room doesn't feel like they belong in this room for all of our inadequacies. All of this is led by folks like yourself, the lived experience. Like, that is what pulls us all forward. So you do belong. We all do belong. You lead it. Are there any questions? No. Thank you. Two microphones has got me going a little bit here. Our final group of speakers in the speaker session before we get to our panel group to finish out the night. I would like to welcome to the crowd, or to the stage, as I get my page here, Rachel Martens, who has been a part of the disability community in varying capacities for over 20 years. She is the bereaved parent to a young man born with medically complex disabilities who passed away in 2020. She is also someone with lived experience of a disability herself as an ambulatory wheelchair user with a neurologic condition. Rachel currently serves as a knowledge broker with the, let me get this right, Israeli Accelerator, and a research engagement strategist with CanChild, where she supports family researcher partnerships and knowledge mobilization. And Genevieve Currie is a parent of a child with a rare medically complex disease. She is a parent advocate, registered nurse, and researcher in rare disease, medical complexity, and disability. She's an associate professor in the School of Nursing and Midwifery at Mount Royal University here in Calgary. And she sits on several national committees around concerning rare disease and medical complexities, including as co-chair of the Children with a Medical Complexity Network with Children's Healthcare Canada. She also works with CanChild Centre for Disability Research to deliver family engagement in research courses for caregivers, researchers, and clinicians.
Hi, everyone. It's very happy to be here to talk about Envisage, which has been near and dear to my heart for a number of years now, actually. As mentioned, my name is Ray Martens. I had the privilege of being mom to a young man born with something called mosaic trisomy 22 back in 2006. He passed away back in 2020. And if there's one thing that I took away from the experience was the day he passed away, my spouse kind of looked at me and said, "We did good." And that's really something that's kind of sticks with you for the rest of your days, because I think that's something that, be it a lifelong or short, we always kind of knew that we wouldn't have him for, he was going to dictate whenever that was, whenever he passed away. And for him, it was, he decided that, and we've realized how much we did good. And we want that for other families here as well, too. Genevieve.
Yeah, thank you, Ray. So Genevieve Currie, as you heard, I have a son with a rare medically complex disease, and I also have the hat of a researcher and the hat of a nurse. And so I became involved in Envisage, wearing all those three hats in the Envisage for Service Providers group. And so as a nurse researcher and a parent. So I help co-facilitate that. So we're going to talk to you a little bit about Envisage. Goes quickly. Okay, so that gives you some idea about Envisage, and how Envisage came to be was that a group of researchers and parents asked other parents who had children with disabilities, if you could do anything differently and you had choice when your child was young, what would have made a difference for you? And based on what you know now, what would you have liked to have known then when your child was young? And so they really talked about having support for caregivers and support for the family and seeing the family within the child within the context of the family. So if you have a healthy family, you're more likely to have a healthy child. So this was a direct shift away from a deficit-based, illness-focused limitation on disability to how can we support families in family-centered care, strength-based care, and focus on what the child and family need within the community to participate in day-to-day life.
So with what's unique about the Envisage team is that it's an international team of researchers and caregivers and clinicians across Australia and Canada. And we designed this together at the same time, but also readily acknowledging some of the cultural and country-related differences that might also come together. But it was planned between the lot of us how things worked out. So the original partnership was comprised of McMaster University, Australian Catholic University, Murdoch Children's Research Institute, as well as University of Melbourne in Australia. And to start things off, we had over 100 families and 20 service providers contribute to the development of Envisage before we even moved towards implementation.
And so Envisage recognizes that due to a cumulative effect of caregiver strain, so families caring for the often unmet care needs of children, there can be physical, psychological, and definitely socioeconomic burden and strain. And that this is often not recognized or not acknowledged, and so over time can really affect the caregiver. And so it's, again, a different way of thinking and feeling and talking about disability so that we really consider, again, the family and the child within that family and what the caregiver needs in order to provide excellent care to the child and to themselves and the other siblings in the family.
So it wasn't only readily acknowledged, but completely understood in the design of the program that the team, as well as the advocates, all said that the most important people and your child's first hero or like your first champion is the parents. And so they needed, parents deserve a sense of well-being as well too, as they create best starts after a diagnosis. The objectives for the program are things like feeling confident and competent in your parenting decisions, increasing skills in communication with service providers, being able to make choices that are informed by contemporary evidence-based and evidence-informed ideas, and connecting with other caregivers to improve parent and family outcomes. So what's also unique about that is the diagnostic criteria within the rare disease world. Sometimes you just didn't fit something that said only autism or only CP, but in reality, like my son's condition was a chromosomal based one, and he also had cerebral palsy as well as autism. But at the same time, some people don't necessarily have that depth and breadth of information, so they don't necessarily know that they fit. So families would be in groups that actually were cross diagnoses. It wasn't for like one specific camp or of diagnosis. We were all just parents in one room. And that was just very unique to me, not only as a parent and a parent partner, but also just from a research standpoint as well too, from what I've seen. And it's also important to mention as well too, just the fact that we have for our website, an artist who is from Eastern Torres Strait Islands. Her name is Jordana Angus Wiradjuri, who did all of the art for our website because we have a Envisage First Peoples version as well too of this specific program. Participants were aged between, like the children of the parents who participated in the study were between ages 1 and 6 with a wide variety of diagnoses. And the workshops were facilitated between a parent peer like myself. I was a part of the pilot for the Initial Families program and a service provider. And so at the time when we initially did that, that was with, I was with a clinician as well too. Each workshop is supported by online self-directed learning materials, a variety of activities and resources that really prompt a person to think about their values and how they fit within the complexities that come with parenting decisions when there's a diagnosis involved. And families have essentially told us that it provides them with the time and the space for reflection and tools and strategy for decision-making and an opportunity to connect and collaborate with other caregivers with a shared experience of raising a child with a developmental condition. And honestly, I started this back in, I think it was 2018, and I'm still hanging out with some of the parents, which is just wonderful. And I've seen them through some just significant points in their lives as well.
Good point, right? This slide is showing that this has been co-created, co-designed with parents, researchers, and clinicians. So it started out as a partnership with parents, and then every step of the way, parents had input into the workshops, as Ray just mentioned, the 5 workshops. And then the workshops were eventually, the content was shared with parents with surveys and interviews for feedback. And then the workshops were piloted. And then eventually now the Envisage is being offered in Canada and Australia, and is also being researched as well to look at outcomes from that. So again, it co-created, co-designed all along the way, and it continues to be adapted and changed based on parent feedback.
So when we started the first pilot, certain global things happened. It was about 2020, if this rings a bell for anybody. So when it came to making that transition, the one thing that we did ask families was, is it okay if we do this online? And I don't know about any other caregivers in the room, but the idea of doing something in sweatpants and not having to get ready for something is pretty rad. So there was no hesitation to make that transition.
My child is a storybook and not a textbook. In order to understand him, you need to look at his whole story. You need to look at who he is, who's around him, what's involved in his world. And Envisage truly gave me the tools necessary to be able to do so, and the confidence.
So that's Elizabeth Chalmers, who's one of our founding parent partners in Envisage, and her son, William. And so she's giving you the perspective that Envisage was really saying that he's not a textbook, he's a child, was part of a family, and he's individual, and get to know what the needs are of that family instead of relying on outdated information or information that is not individualized and applied to all children.
So when it comes to long-term impact, you can definitely see that this resonates with me personally, what the person says in this quote. When I think about the first time I went to like a diagnosis-based event, I was told what the diagnosis was, what it wasn't, and then I had to, in that same evening, pick my life-changing early intervention therapy. And that's a lot to take in. And so when I think about the idea of being strengths-based, but then also like being empowered as a parent and finding my confidence in this quite complicated sphere for some of us, that was quite personally impactful for me, just even as a partner, to be a part of that. But then to see that long-term impact down the road at 12 months was just significant.
And so Envisage was launched in 2018 in Canada, and then in Australia in 2019. And then globally, it's been through PhD students. So in 2020 in Croatia, and now it's being looked at and underway in Denmark. And then in 2021, the parents who were taking the course and the parents who also were giving feedback about the course said, well, what about the service providers who work with our children? And wouldn't it be great if they had the same material and a way to talk and think about disability in a different way? And so Envisage for Service Providers was launched, and I was one of the co-facilitators for 2 of those national programs. And I wore the hat, like I said, as a nurse, a researcher, and a parent, as did my co-facilitator, had similar credentials. And so we really found that service providers appreciated the fact that we also had some lived experience as we worked with them to think about disability in a different way. And so this quote came from one of the participants, service provider, who took the course. And so certainly the idea that people are practicing family-centered service, they're trying to put into life some of the things that they believe in, but they've told us that through Envisage, they got permission to focus on family-centered service and to not just focus on the child, but to actually ask the family, well, how are you doing? How are things going for you? What can I help you with? That can be scary, but that's often what needs to happen to even find out what some of the bigger issues are that are affecting the family. So the service provider cohort then are trying to, again, dialogue and meet and bring some of these ideas forward to their institutions and their child treatment centers as well. So certainly we would love for you to connect with us. Our administration would love for you to connect with us. So there's our email and the website for Envisage. And Envisage is always looking for other opportunities to offer this program and at other child treatment centers. So please reach out if you're interested. Thank you.
I've got a question. Is there any specific way that clinicians and researchers at this date can help support programs like Envisage? Is there anything specifically with Envisage that we can get involved with?
Well, right now it is being implemented in Australia. It is being fully funded within, I can't remember which area of Australia, but like the government is actually they have it fully as a part of the system. So for us, the next step really ends up being, what would that look like implementing that in like at a province to province basis, and really talking about the fact that this is helpful to make those best starts that you wish to see post-diagnosis. And the fact that this is really an induction into the disability community that helps them better understand something they might not necessarily be familiar with in that case as well too. So that to connect with the team about that implementation phase and about the advocacy surrounding that would be a really significant next step.
Any other questions from the floor? Thank you so much.
Oh, I need it.